Good morning everyone. Myself Dr. Naga Supraja from the Department of Pediatric and Preventive Dentistry. Today's topic of discussion is on infant oral health care. These are the contents under which it will be discussed. Coming to the introduction, oral health is the integral part of the general health and it plays an important role in improving the quality of the life. With increase in the number of teeth erupting and the dietary practices during the infancy, it increases the risk of the oral health infections. The main goal for the infant oral health is to break the caries cycle which once started and it continues through the childhood. For the oral health management, 4 interventions are required. They are mainly the screen, wean, clean and fluorine. The main goals are the identify the risk factors and also incipient disease as soon as possible and control the child's exposure to the sugar. Institute the plaque removal to reduce the bacteria. Impart maximal fluoride protection. According to the American Academy of Pediatric Dentistry, infant oral health is defined as the professional intervention within the 6 months of the life after the eruption of first primary teeth or no later than 12 months of life, directed at factors affecting the oral cavity, counseling about the oral diseases, risks, delivery and the anticipatory guidance. Coming to infant oral health care, dental caries and also the gingivitis plays an important role in the infectious disease which begin in the infancy. Infant oral health care begins with the prenatal counseling for the parents and also the postnatal initial oral evaluation. The main goal of the infant oral health is that according to the American Academy of Pediatric Dentistry, the first dental visit should start as early as possible, that is within 6 months of eruption of the first primary teeth. The goals of the first dental visit is to familiarize the children with the dental setting and various type of dental treatment, to provide the infants, toddlers and children a pleasant, fun-filled, enjoyable, non-threatening introduction to dentistry, to introduce and encourage a preventive philosophy, to determine the relative risk and susceptibility of the child to dental disease, to detect the presentation of early dental disease. Coming to preparation of the child for the first dental visit, make the appointment at a time which is suitable for the child, usually in the early mornings. Clarify all the doubts and apprehensions you may have by talking to the dentist before your child's visit. Read a storybook or watch a film about going to the dentist. Play the dentist with the child. Do not express your fears of dentistry in front of the child. Do not promise the child that there will be any pain or the hurt the dentist will give you, and carry all the previous relevant medical or the dental records. Let the child carry his favorite toys to the dental clinic and allow the time for the child and the dentist to get acquainted. Recommendations for the parenteral oral health, it includes oral health education for the mother to prevent the early childhood caries and educating the parent on avoiding the saliva sharing behaviors which can help prevent the early childhood caries, and oral hygiene, as the parent to use the fluoridated toothpaste and also flossing needs to be done, which will help to dislodge the food and reduce the bacterial plaque levels. Dietary education of the parents is also necessary to reduce the cariogenicity of the certain foods such that they can help to prevent the formation of early childhood caries in the child. Comprehensive oral examination is needed during the pregnancy for the mother, and professional oral health care is required to optimize the oral health of the parent. And coming to the fluoride, it is recommended that about 0.05% sodium fluoride once a day or 0.02% sodium fluoride rinse twice a day is suggested. Xylitol chewing gum. Xylitol chewing gum for at least 2 to 3 times a day by the mother is suggested. Coming to concepts of infant oral health care, anticipatory guidance is defined as the proactive counseling of parents and patients about developmental changes that will occur in the interval between the health supervision visits, that includes information about daily caretaking specific to that upcoming interval. It should be started from 6 to 12 months. The 6 main areas under the anticipatory guidance, it includes oral development, fluoride adequacy, oral hygiene, diet and nutrition, habits and injury. General anticipatory guidance for the mother, it includes the oral hygiene, diet and fluoride. Fluoride is suggested at a rate of 0.05% sodium fluoride. Caries removal. Routine professional dental care for the mothers can help to prevent the formation of dental caries in the mother, and removal of active caries with subsequent restoration is important to suppress the maternal mutant streptococcus reservoirs and has the potential to minimize the transfer of mutant streptococcus to the infant. Delay of colonization. Education of the parent regarding the colonization of mutant streptococcus helps to prevent the formation of the mutant streptococcus in the oral cavity, and the xylitol chewing gums are advised. Coming to the general anticipatory guidance for the young patient in the age of 0 to 3 years of age. Regarding the oral hygiene measures are taken no later than at the time of the eruption of first primary teeth. Cleaning the infant's teeth as soon as the primary teeth erupts into the oral cavity should be started either with the soft toothbrush, which will help to reduce the bacterial colonization. Coming to the diet, high-risk dietary practices appears to be established early, probably by the 12 months of age, and frequent nighttime bottle feeding and libitum breastfeeding and extended and repeated use of the sippy or no sip cup are associated and not consistently complicated with the early childhood caries. Coming to the fluoride, optimal exposure to the fluoride is important to all the dentate infants and also the children. Twice daily brushing with the fluoridated toothpaste is recommended, and systemically administered fluoride should be considered for all the children, and it should be less than 0.6 ppm. Caution is indicated in the use of fluoride containing products. Coming to injury prevention, practitioners should provide age appropriate injury prevention counseling for orofacial trauma. Initially, discussions would include play objects, pacifiers, ear seats and electric cords. Non-nutritive habits. Non-nutritive oral habits may apply forces to the teeth and also the dentavolvular structures. It is important for the dentist to discuss the need of early sucking and the need to wean the infants from these habits before malocclusion or skeletal dysplasias occur. Coming to dental home, it is defined as the ongoing relationship between the dentist and patient, inclusive of all aspects of oral healthcare delivered in a comprehensive, continuously accessible, coordinated and family-centered way. The establishment of dental home begins no later than 12 months of age. The guidelines include the comprehensive oral healthcare, including acute care and preventive services, comprehensive assessment of oral diseases and also the conditions, individual preventive dental health program based upon the caries risk assessment and periodontal disease risk assessment, plan for acute dental trauma and anticipatory guidance regarding the growth and developmental issues, dietary counseling and information about the proper care of child's teeth and gingiva. Referral to the dental specialist can be given. Education regarding the future referral to dentist, knowledgeable and comfortable with adult oral health issues for continuing oral health care. Referral at an age determined by the patient, parent and the pediatric dentist. Characteristics of dental home include it should be accessible, family-centered, continuous, comprehensive, coordinated, compassionate and culturally competent. Advantages include it emphasizes the importance of early intervention with optimal preventive strategies chosen based on the risk of patient and would encourage the first dental visit by approximately 1 year of age. Parents welcome professional support and anticipatory guidance to ensure that their children have healthy mouths at this age. Practitioners can provide the personalized preventive approaches for the children based on their family history and oral examination and the risk factors identified, which includes the medical history, dietary habits, medication, fluoride availability and the parental attitudes. Another advantage is that preventive intervention can be personalized at the needs of the child. Risk assessment remains as emerging science, although suggestions are available for the children who are at the greater risk. Coming to the specialized care referral, dental home specialized care referral would add more advantage to the dental home concept. The continuous care provided by the dental health team also recognize other developmental milestones which may need further attention in the future. When the child is associated with the speech problem, they can be referred to the speech therapist. Caries risk assessment. American Academy of Pediatric Dentistry defined caries risk assessment as a determination of likelihood of incidence of caries during a certain period of time or likelihood of that there will be a change in the size or activity of the lesions already present. Risk assessment is the estimation of likelihood of that event which will occur in the future. To achieve the best management and outcomes of good oral health, the caries risk assessment should be done as early as possible, preferably before the onset of the disease. Caries in the primary dentition is a strong predictor of caries in the permanent dentition. The caries risk assessment should be done at the beginning of the age of 1 year, and information obtained through the caries risk assessment can guide a disease management care path tailored to an individual's age and risk to effectively treat and manage one's caries disease process. The goals of the caries risk assessment are: screen out the low risk patients, identify high risk patients before they become active caries, monitor the changes in disease status in caries active patients. Another important risk factor in the young children is the age of mutant streptococcus colonization. Early childhood caries is an infectious process that too frequently requires expensive and extensive intervention. Identifying the factors will help to determine the individuals with high caries risk such that we can prevent the recurrence of the disease. Coming to methods and models for assessing the caries risks, it should be considered from the two perspectives: the assessment methods used by clinicians in examining the patients and also in making the decisions in treatment planning and case management, and the assessment methods that have been studied in the prospective research studies. Coming to caries risk assessment tool, it includes the clinical conditions, that is low risk means there is no caries teeth in the past 24 months, there is no enamel demineralization, no visible plaque or no gingivitis. Moderate risk is caries teeth in the past 24 months and one area of the enamel demineralization and gingivitis. High risk patient, there will be caries in the past 12 months, more than one area of enamel demineralization, visible plaque in the anterior teeth, radiographic enamel caries, enamel hypoplasia, wearing dental or orthodontic appliances. Environmental characteristics include: in the low risk patient there will be optimal systemic and topical fluoride exposure, consumption of simple sugars, high caregiver socioeconomic status and regular use of dental care in the established dental home. In the moderate risk patients there will be suboptimal systemic fluoride exposure. There will be about 1 to 2 between meal exposure to simple sugars, and mid-level caregiver socioeconomic status, irregular use of dental services. In the high-risk patients, there will be suboptimal topical fluoride exposure and frequent exposure of simple sugars in between the meals, and low-level caregiver socioeconomic status, no usual source of dental care. Active caries present in the mother. In the general health conditions, in high-risk patient, there will be the children with the special healthcare needs and conditions impairing saliva composition or the flow. Caries management by the risk assessment, it is CAMBRA. It is specially designed for the use of newborns to 5-year age children. It is easy to use and offers an approach to disease prevention management that integrates risk assessment of the childhood caries as an integral component of the comprehensive oral health visit. The caries balance concept states that progression or reversal of dental caries is determined by the balance between pathological factors and protective factors. The The pathological factors include acid producing bacteria, frequent eating or drinking of the fermentable carbohydrates, subnormal saliva flow and function, and the protective factors include saliva flow and components, fluoride, remineralization with calcium and phosphate, antibacterials, chlorhexidine, xylitol, and others. Protocol of the infant oral health care. A protocol was established by the University of Iowa to assist the dentists in their efforts to meet the growing requests of the parents of infants or the toddlers for early evaluation and assistance in dental disease prevention. It includes pre-appointment questionnaire, interview, examination of the infant. In the pre-appointment questionnaire, there will be a packet of information which should assure the parents about the concept of the infant oral health care and supportive of their efforts to prevent the dental disease, and a welcome letter congratulating them on their initiative in seeking the proper health for their children, and information on patient registration, information regarding the child and the family. And it also includes a growth and development to know about the age at which the milestones of development like sitting alone, crawling, etc., and feeding practices to assess the potential for nursing caries by discovering potentially harmful habits, prenatal, natal, and neonatal history. It includes providing the information regarding the dental developmental abnormalities and medical history to know whether there is any systemic disorders, and dental history. It gives the clue to the potential dental problems. Coming to interview, through the interview, it helps to assess the dental awareness of the parents, their perception of dentistry and dental disease, and also the history of tooth decay in the family. Fluoride inventory, to know about the fluoride, water fluoridation, fluoride supplements, and fluoride dentifrices. Children who are totally breastfed should receive appropriate fluoride supplementation until they are weaned or begin drinking fluoridated water. Tooth cleaning, should know how the infant's teeth are cleaned and by whom and when. Diet assessment, child eating patterns, snacking habits, and the type of snacks given to the child. Coming to examination of the infant, it should be done in the knee-to-knee position, where the upper legs of the parent and the doctor form the examination table. Dentist can easily and gently stabilize the child's mouth and head crappled in the lap, while the parents hold the child's hand and can stabilize the legs by cradling with the elbow examination procedures. The requirements include adequate light and assistance to help our parent, soft touch evaluating extraoral head and neck conditions first, and fingers to palpate the oral structures. Access and stabilization of the mouth can be obtained by placing a finger in the gum pad distal to the most posterior teeth. Dental cleaning with a soft bristled moist toothbrush. Infants who exhibit tight contacts, tendency of plaque accumulation, so the parents are taught using the dental floss. Gentle restraint of the child is necessary, towards which the parents and consultant can contribute. Oral characteristics of newborn include maxillomandibular relationship, forwardly placed maxilla in relation to the mandible, that is pseudo appearance of micrognathia, and edge to edge maxillomandibular relationship at birth, backwardly placed mandible, and correct maxilla mandibular relationship developing after the birth, physiological sucking exercises. Coming to the lips, lip counter will be triangular, and after the birth, the frequent feedings lead to the formation of the sucking callus. The attachment of the lip frenum is variable, ranging from a few millimeters above the alveolar ridge margin to the extent above the alveolar margin to the incisive papilla. This constitutes the so-called persistent tectolabial frenum, which enhances the breastfeeding by providing greater support to upper lip. Coming to the diet counseling in infants. American Academy of Pediatric Dentistry recently issued a policy statement on the prevention of pediatric overweight and obesity. It also recommends that breastfeeding as the ideal method for the infant feeding, and with exclusive breastfeeding for the first 6 months, followed by addition of iron-rich solid foods between 6 to 12 months of age. And bottle feeding infant formulas are mostly acidogenic and possess a karyogenic potential. Therefore, parents need to be made aware of the deleterious effects of the inappropriate use of the bottle usage and weaning. American Academy of Pediatric Dentistry also suggests that the breastfeed should be done for at least 12 months and thereafter for as long as the mutually desired. Dietary fluoride supplements are the child should be given at least 0.05 milligrams of fluoride per day. Irrespective of fluoride exposure in water, dietary supplements should not be prescribed for the infants under the age of 6 months. Fruit juice consumption. AAPD suggests that infants should consume only 4 to 6 ounces of fruit juice per day, and it also cautions that fruit juice offers no nutritional benefit for infants younger than the 6 months. Cereal consumption. Only iron fortified infant cereals along with the breast milk or infant formula should be given to the infants who are older than 6 months of age. Food and choking hazards. Parents should be cautioned regarding the potential of various foods to constitute an infant choking hazard. AAPD suggests the food given to the infant should be smashed or cut into small, easily chewable pieces. Infants should never be given of nuts of any type, sunflower seeds or watermelon with the seeds. Coming to oral hygiene aids in infants, it includes the oral hygiene is maintained by using the tooth wipes, oral gel, gum massages and dentifrice. To conclude, the infant oral health is a foundation upon which the preventive education and dental care must be built to enhance the opportunity for a lifetime free of preventable oral diseases. This would improve access to the dental care, especially for the poor and the minority children who suffer from the dental caries and who have limited access to the dental care. These are the references.